Pleasure to see everyone. So today I've been given a title, No Brain, No Gain, and I've subtitled this Pain and the Mind-Body Front Line. So basically what I'm going to try and do for you today is give you a much better understanding of how pain actually works, what the role of the brain is in this, and hopefully that understanding will help you to manage the condition better. So just understanding more gives you power. So I think everybody here will be familiar with this. So the interlink between hypermobility, pain and stress, and physical deconditioning. So you have the hypermobility, you have the irritable muscles, that gives you the pain. The more pain you have, the less you can use those muscles. That means they get more unfit, more deconditioned, more irritable. So you have less support to the joints, and it all feeds off each other. And I'm sure everybody here is very familiar with this as a problem. So I have to start off with, because I'm talking about pain, what is pain? You might think that's a very strange question to ask, and everyone in this room must be absolute experts at knowing what pain is. But it's actually more complicated than that, because pain isn't one thing. There are lots of different types of pain, and there are lots of different mechanisms contributing to that pain. Now, one way of thinking about pain is to talk about acute pain and chronic pain. So let's talk about that. So what's acute pain? Everybody here will have experienced acute pain. That's the pain you get when you fall over and stub a toe, when you cut your finger, when you burn yourself. It's when you cause damage. And if you've got damage, that activates pain receptors. Those pain receptors fire and make your pain nerves fire. That will transmit pain signals to your spinal cord. There are relays in your spinal cord, and that transmits all this signal up to your brain. Then your brain has to process all of this pain information and react. Ouch, I've got to do something about this. So it's going to switch on behavioral emotions, behavioral responses, and we've already just heard very eloquently about how pain has to switch on stress centers. So it does switch on your fight and flight stress responses. So this is your sympathetic autonomic nervous system. And once you've out of the danger, once the damage is repairing, you'll enter the rest and repair phase. Now that's the other side of the autonomic nervous system. That's the parasympathetic side. So this is the sort of thumbnail sketch, if you like, of acute pain that we've all experienced. And you can dress it up with really complicated diagrams like that. And this is the sort of complicated diagram that gets put up at various complex pain conferences. But actually, you can bring it down to really simple. All it's showing is that you've got your pain receptors, they're firing, it's making the signals come in through the nerves are going into a special area of the spinal cord called your dorsal horn. That then has relays in it that send the signals up to your brain, so now it's going right up to the brain. The brain is now having to try and process all of this information, and then there are some very other interesting bits here which I'm going to touch on later, which are the descending systems. So we'll talk about those later. So it's a really complicated diagram, but actually you can bring it down to a nutshell and make it much simpler to understand. So why is pain so important and so pervasive? And the answer is because it's an evolutionary survival system. There are some rare genetic conditions where you cannot feel pain. You die younger if you have those. If you don't feel pain, you don't know you've got an infected cut. You don't know you've got a dodgy appendix. You don't know you've got pneumonia, so you die. So pain is an evolutionary protective signal. We have to have it. That's why it's so hardwired into us. So pain is signaling damage, and in terms of evolution, if you're a caveman or a rabbit, it doesn't really matter, you've got damage. You have to have a signal that stops you using the damaged bit. Evolution came up with pain, and by it does it work. So you stop using it. Then the idea is that it will start to repair, and then as it repairs, you will switch that signal off, and you'll go back to using it. So that's the system that it's supposed to be. Now, anything that's causing damage, in terms of evolution, is dangerous. You need to get out of that situation. You need to get out of that situation that's causing you damage. So it has to switch on your stress centers. It has to switch on your brain emotional and behavioral centers. The odds are, in terms of evolution, if you've got pain and damage, you need to be terrified and run away, or you need to be angry and stand and fight. So it has to switch on these centers in your brain. So you're starting to see now the key importance of your brain. And I couldn't resist putting up Monty Python. I mean, who can't? So again, why is pain so pervasive? Chronic pain is more complex. In chronic pain, this system's going wrong. So you might have had damage, but it's long since gone. But for whatever reason, that signal, in this case pain, is still running. That off switch has never happened. So now you have a constant on signal, a constant signal of pain, constantly going to the brain that your brain is trying to deal with. So now pain isn't about damage anymore. It's about a faulty pain system. And this is where it becomes very problematic. Okay, so let's talk about pain in terms of hypermobility. So what sort of mechanisms are contributing to pain and hypermobility? And that's from any cause, whether it's EDS or any genetic condition causing hypermobility. But they're going to be the obvious ones. You can get the dislocations and the subluxations, and everyone here knows how painful those are. You can get ligament damage, ligament rupture, ligament instability. I've put a question mark next to secondary osteoarthritis. That means wear and tear arthritis. Some people think that because the joints move more, might it make you more susceptible to getting wear and tear arthritis later in life? Other people say no, precisely because it can move more. You've got more compensation, if you like, so actually it might be protective. And the answer is we don't know. And this will be a show of hands. How many people here were told from childhood they were clumsy? They were the ones that would fall over the blade of grass, walk into the doorway. Yeah, lots of hands. So there seems to be an interesting link that I see an awful lot of people with EDS who are also very, very poor with their proprioception, so knowing where their body and joints are in space. I probably see a lot more people with dyspraxia, or people that probably got dyspraxia but it's never been diagnosed. And again, that's a fancy way of saying the brain's just not very good at putting together body sense information, and it tends to make you quite clumsy. So if you're clumsy, you're going to get more injuries. And then there are the muscles. The muscles in EDS are often extremely irritable. I'm sure everyone here has had the spasms and the tremors. And we've already mentioned that in pain, if you can't use the muscles and the joints the way you normally should, they'll start to get deconditioned. And the worst thing you can have is a very deconditioned, weak, but very irritable muscle. That's really hard to retrain. You can get muscle damage, so you can get muscle strains, you can get muscle sprains, muscle tears, you can get damage to tendons and to ligaments. And if you've got a painful bit, your body will try and compensate. It's natural. So if you've got a painful knee, you will typically shift and try and take the weight off, but that means the other side's going to be taking more weight, so you're going to start to get overuse problems. Because the joints can move further, you can sometimes get nerve problems. And again, if you're overusing things, you're much more prone to things like tendinitis and bursitis, and I'm sure there's lots of people here that have experienced those. And then again, we've already heard a little bit more from my colleague here about the whole role of the neuroendocrine system. Now that's again a fancy way of describing how the brain and hormones all coordinate in stress. So there's an area in the brain called the hypothalamus that's very, very involved in regulating things like stress hormones, and this is all coordinating the response of the brain and the body to stress. And we've already heard about the critical role of the autonomic nervous system, and that pain and stress activate the sympathetic arm, which is your flight and flight side. So this is what's being wound up in pain. Now, I often teach doctors, and I often teach pain doctors as well. And if you go to these big pain conferences, you will hear anaesthetists and pain doctors talking about complex concepts such as peripheral sensitization and central sensitization. And these are thought to be really important in chronic pain. But like all things, you can actually bring this down to what's the bottom line? What does it mean? Bottom line for peripheral sensitization, you can read books and books on this, but the bottom line is pain nerves fire more easily. Those pain receptors can fire from stimuli that before wouldn't have been enough. Now it is. So those pain receptors fire more. That means the pain nerves fire more. So you've got a barrage of information coming in to the spinal cord. So everything fires more easily and more often. Central sensitization means how the entire system winds up at the level of the spinal cord and the brain. So we've already seen the pain nerves will come into the spinal cord. There are relays there. Those relays are firing more frequently. They're firing more often and more easily. So now you've got a huge barrage of pain information coming up to the brain that has to try and do something about this. And that whole complex system is called central sensitization. So as we've said, you've got a barrage of information now going up to the brain which has to handle this. Now again, in terms of evolution, if you just got overwhelmed by pain, it wouldn't be very good. If you've got overwhelmed by pain and froze, you'd be eaten. So the brain's actually quite clever. Your brain can actually tune up pain and it can also tune it down. So if you tune it up, you facilitate it, or you can turn it down, and that actually inhibits it. Now, we've just in the last couple of decades, probably, only recently really, started to get interested in trying to understand these descending control systems that happen at the level of the brain. Now, it happens in an area called your brain stem, and as I say, there are some systems that can tune it up, and there are others which we call descending inhibitory control that can actually tune pain down. And we know that in some chronic pain syndromes, such as fibromyalgia, that these descending controls are faulty. They are not damping down the pain the way they should. And perhaps some of the facilitatory ones are doing too much. So there's much more interest now in understanding these systems. And that, by the way, is just, that's bad descending control. Again, I couldn't resist putting that up. So just giving you a thumbnail sketch, I hope you're seeing that individuals vary, and so do pain mechanisms. So the sort of pain you're getting at this point and the mechanisms contributing to that, that might not be the same as in, say, 6 months' time or a year's time. And furthermore, what's happening for you may not be happening to your neighbour next door. So we're all individuals, and so we're all going to have different ways that this is contributing. But have you also noticed how if you've got one chronic pain syndrome, typically you've got others? So again, we'll have a show of hands. How many people here also have diagnoses of things like fibromyalgia, chronic fatigue, pelvic pain, TMJ dysfunction? Yeah, I thought so. That's more like it. And again, that's reflecting the fact that some pain mechanisms happen in all of these conditions. So which takes me across to this. This is the concept of something called centralized pain. And again, to put a complex concept into its baseline, pain itself can change how pain works. So you can get more pain with less provocation. It's almost like someone's taken the volume knob for pain, turned it up on high, and left it there. And you are now stuck, tuned to that system, and you can't turn it down. And that's basically what centralized pain is. And if you think of that as the background that's happening in all of these chronic pain syndromes, that explains why they all overlap. So I know there's often a lot of arguments and debate about whether things like fibromyalgia are wrong diagnoses. I see it more as a co-diagnosis. If you've got pain that long, you're going to have these systems working. And these systems work in all of these other pain conditions, and that's probably why they overlap. So as you've already gathered, I've got a lot of interest in the brain and how brain understands pain. So let's talk a bit more about that. Which allows me to talk about interesting things like qualia. Now, the qualia is actually a philosophical term. It describes the perception of a sensation. So the color of a strawberry, the smell of a strawberry, the taste of a strawberry is a qualia. They are the perception of a sensation. But the trouble is, I have got no idea if the red that I'm seeing on that strawberry is the same as you're seeing, if the smell and the taste is the same as you're experiencing. And the problem we have is pain is also a qualia. It is a perception of a sensation. And the big problem when trying to understand pain, and particularly research pain, is I cannot know that what I feel as painful, whether you would feel as painful, whether you would say, nah, that's nothing, or whether you'd be saying it's agony. We just don't know. So that's one of the main problems and one of the main barriers trying to understand pain. Which takes me to that slide, which is basically illustrating the same sort of thing. So on that side, these people are participating in something called the Thai Pasam Festival, which happens around Malaysia. It's a religious festival, and people deliberately impale themselves with all sorts of weird stuff. And yet, apparently, they don't experience pain. If anything, they're experiencing pleasure because they are taking part in this. On the bottom there, if that's Guantanamo Bay, it's torture. In a German S&M parlor, it's pleasure. And yet, in all three slides, if you bring it down to physiology, you've got pain nerves firing. It's the same pain nerves, it's the same pathways to the brain, and yet how we respond to it, how we perceive it, and the emotions are totally different. And it really surprises me that, again, it's only really in the last couple of decades there's been any real attempt in pain research to understand the importance of perception and pain. And what happens when brains just get confused and struggle? So your brain, second to second, every day, is having to put together, integrate a lot of very complex information. It's having to put together visual information, sensory information, information about the surroundings around you, or listening information. It's having to put this together all of the time so you can make sense of where you are, the environment you're in, and how to respond to it. Now, what happens if those systems just get overloaded and they don't work very well, and that whole integration process starts to get fuzzy? The best example I can give you is seasickness. So again, let's have some participation. If I threw everyone here on a small boat and took us out on a rough day on a choppy sea, hands up how many would be seasick? Yeah, because lots of us. And yet other people wouldn't. But we're all on the same boat. We're all experiencing the same thing. So we've got visual information, that's conflicting with balance information, that's information from your middle ear, that's conflicting with your muscle information, your muscle tendon information. If your brain can put that all together, you're fine. If your brain struggles to put that together, you're sick. You're horribly seasick. And yet we don't think that's something wrong with you. That's a consequence of your brain cannot put it together. Equally, if I left us all on that boat for 2 weeks, we would eventually not be seasick anymore. We'd get our sea legs, as they call it. And that's because we've learned how to put that information together. So I'm interested in what happens when you really upset brains. They can't put that information together. If you give me a mirror, and I do some movements with you, and a lot of people, I can create pain just by confusing visual information and muscle information. So yes, confusing brains causes problems, and this is an example. That's a picture by an artist called Bridget Riley. I wouldn't want it on my wallpaper. That is giving you a lot of visual conflict, so it's your brain having to put together a lot of conflicting visual information, but that's quite migrainous, quite sticky feeling. I would not want that on my wall. Similarly, that one should be even worse. As you look around it, it should be moving. It's not moving. It's your brain misapplying rules of contrast and shadow, because again, it's getting confused, that makes it apparently move. But again, that's quite migrainous, quite sick, but it's just a picture. That one I think is even worse. That one moves in a wave. Again, you wouldn't want that on your wall. So yes, confusing brains is enough that it can cause problems. So what's the relevance to everyone here? Well, I hope I've demonstrated how vitally important brain and body interaction is. You can't separate one from the other, and to try to is silly. Pain, stress, emotion are physiological and psychological processes. They all feed off each other. We can think of chronic pain as a neurophysiological maladaptation, if you like. If you've got chronic pain, anxiety and depression are really common as a consequence of that. And it's almost like that's a result of having chronic pain. I'm sure some of you here would have also experienced the brain blurring, just this integration starting to fall apart. So a lot of people will just not good at knowing where the body is, but a lot of people have that limbs feel bigger and heavier than they are. And this is the sort of what we call phantom swelling. So this is, again, brains just not really struggling to put information together. And then there's all the associations that go along with chronic pain. So poor memory, poor fatigue, we've already heard some of this. The sensory sensitivity, so everything's just that little bit wound up and sensitive. So you're sensitive to touch, to light, to bright lights, to loud noises, to strong smells. Again, it's reflecting a wound up system. And if that isn't enough, the drugs don't do much. But if you've just seen, and I hope what I've demonstrated, is if you're seeing how complex a system pain is, it's not really surprising that the drugs don't do a huge amount. They take the edge off, but they don't make it go. So what tips can I give you for that? Very simple. Recognize that we are working in what's called a Western model of medicine. And the Western model of medicine is, if there's an ill, there's a pill. Unfortunately, it falls apart when you've got ills that there aren't pills for, or the pills aren't very good. So recognize the limits of your medication. Get a balance that works for you. If you're on stuff that the side effects are outweighing the benefit, why are you on it? Keep a good relationship with your GP, because they are the ones that have to deal with you day to day. They will know more about you as a whole than your specialist, who you might, if you've got one, see once or twice a year. You might be referred on to a pain clinic for more specialist medication advice. You might even get referred on to a pain management program, such as the ones that we run. So why does this matter to me in rehabilitation? Well, that's because if people have got pain, you often get these sorts of problems, and these can really make people struggle to be able to do rehabilitation. Kinesiophobia is a fancy term for describing that because pain now causes, when you move, you get pain, it describes that whole fear of movement. So kinesiophobia, the fear to move because it causes pain and causes problems. People are often really frightened of doing anything that will cause a flare, because we know how bad flares can be. If you've got chronic pain, particularly with anxiety, depression, it saps motivation. If you've got the fatigue, it saps the motivation. Anxiety and OCD can have huge impacts on whether you can do rehabilitation and what. Some people have an internal locus. It's like the brain is now scanning every minute for the next pain or the next symptom, and you actually become super sensitive, so you can pick up signals that before, perhaps 2 years ago, you wouldn't have been able to feel or to pick up. Now you can, because the brain's scanning all the time. Other people do the opposite and absolutely cut off and don't actually want to take any notice of any of the body information, but that can also be a problem. And again, we can have a show of hands here. How many people have a good day, do too much, pay for it for several days? Yeah, it's a classic. That's your boom-bust activity cycling, and that's something that we often try and work with on programs. Most of us, particularly if you've got chronic pain, you've learnt to adapt because you've had to. And so you've got systems that you've adapted to survive. So actually, someone challenging you to change that can be really difficult. I get patients regularly on lists of 20, 30, 40 medications, and that's just crazy. And I get the opposite. I get people that are so afraid of medication because they've either had bad medications or they haven't been listened to that they don't want to be on any. And actually, a really simple pain medication might make a difference. And then, as we've already mentioned, there's that whole stigma of mental health, and not just from the patient side, but actually from the professional side. Most of my colleagues just feel uncomfortable and don't know what to do around mental health. So, depression and anxiety are very common. It's not madness or weakness. Think of it as part of a brain stress response to chronic pain. But if you don't tackle that side, it continually feeds into pain. And I think some of our other speakers have talked a lot more about this. So sometimes you might need counselling, plus or minus medications, to let you get that control back. And that's important to recognise. It's not weakness, it's not madness. That's just the way this can be. So, to summarise really, mind and body, you can't separate one from the other. People in chronic pain often get depression and anxiety, which feeds back into pain. You've probably heard from our speakers there are higher rates of anxiety in EDS, there are higher rates of abuse, adverse child experiences in chronic pain. There's some very interesting research coming out now that people that have to survive childhood adversity, brain and stress systems have to change to get you through that. But those adaptations that happen as a child to get you through that can probably become maladaptive in an adult if you hit chronic pain. And that's an interesting area of research that's just starting to take off. We know there are higher rates of eating disorders and self-harm. It's the key importance of brain and the mind. So why is it so often doctors and patients think you can cut one off from the other? You can't. So to summarize completely overall, acute pain, we've all experienced that. The pills work quite well, and we're much better at dealing with that. Chronic pain, I've given you an idea, it's much more complex than that. And for chronic pain, you need to look at the individual. You need to look at the mechanisms that are operating in them at that time. Keep a balance of medications. Painkillers may help, but don't expect them to take it all away, because they're not going to. They may damp it down enough to get control, but they're not likely to make it all go. Remember and think about the pain, stress, emotion, interaction, how they're all feeding off each other, and that for some people, psychological approaches can be helpful. So don't necessarily be afraid of psychology and psychiatry. It's just another tool in your box to cope. And I'm going to leave it there and not on one of my horrible pictures.
Fantastic, thank you. If everyone could move to a microphone if they have questions in the room. And I'm going to read some from here. If you press on the yellow button before speaking. So this one is for you, Helen. How can we tell if chronic pain is a faulty pain system or constant acute damage?
Try again. There we go, that's better. That is a typically difficult question to answer. I think if you have EDS and you've had it all your life and you're more prone to getting damage, you will get chronic pain and you will get a chronic pain wind-up. But just remember that when you've got a sensitized pain system, that pain is not about damage. That doesn't mean that you can't get injuries on top of that. And if you have an injury, you know your body. And if that injury means that this is different, this isn't my usual pain, I've done some damage here, of course you need to see someone and get some advice. But usually, I'm afraid the answer is mostly it's a wound-up pain system. But of course, you can get trauma and you can get damage on top. So you have to read between the lines, know what your body's like, and know when it's not right for you.
Thank you. There's one in the room here.
I was just wondering if you've run into, because obviously you're finding that people who have ADHD actually have ESD, and are you also running into people being misdiagnosed with personality disorders?
So, yeah, there's a lot of misdiagnosis in both our fields, actually. So in ADHD, very commonly, it's either been missed or it's been labelled as emotionally unstable personality disorder or bipolar disorder. So I'm very used to this concept of misdiagnosis. But it's very important also to recognise, based on the first talk by Chad, one of my main other interests is actually in trauma, psychological trauma. In fact, my whole of my psychiatric model, with a few exceptions, and ADHD's one of them to a degree, is entirely rooted in a trauma model. When you experience trauma, it either gets integrated, as Chad described, or it remains charged, alive, in the moment, and it's regularly activated. And I think over a lifetime where you're struggling with pain and all the other things, all the other challenges of HSD, but also the same as ADHD, it's virtually impossible not to collect up a lifetime of trauma. And that does change things. It doesn't necessarily, I don't like the term personality disorder. I see things in a trauma model. And the reason why I do is because, as Chad mentioned, we now have super effective techniques of processing trauma. I'm also trained in EMDR and EFT, and I would thoroughly recommend that everyone who hasn't already get online and teach yourself how to do EFT on yourself, tapping on yourself. It is life-changing. It's changed my life, it's changed my understanding of my field, and it's allowed me to see things in a trauma model, which allows you to shift things, and therefore it's not as stuck as you're fundamentally flawed. But to say that these experiences don't change you is untrue. They do change you. You harbour lots of beliefs and emotions and resistance and avoidance, but the take-home message is it's entirely, it can be processed where that charge can be completely taken away. It takes a lot of work, though, and tapping on a daily basis, both in response to problems, but also in a proactive way to set yourself up with a positive outlook for the day. Hugely impactful. EFT, emotional freedom techniques, very good.
Thank you. Is there any advice for addressing adherence in ADHD?
Adherence?
Yes.
It's funny. About 10 or 15 years ago, I saw adherence of medications as being like such a big problem. You know, when you see the data on how many people, generally not with ADHD or HSD, forget to take their medication, how much they forget to take their medication, I suddenly realized that adherence was a serious problem. And I actually designed a device which I tried to patent. I shed it in the end because it was just too ridiculously expensive to maintain it. But the device was, and the reason I'm saying this is I think there's a learning from it. The device was essentially a sheath into which you stick your toothbrush, and in the base of it there was a cavity where you could slide your pill sheets inside a little cup on the bottom. And the idea was every time you went to brush your teeth, you would visually see your pill sheet there. You'd open it up with the cup and take the pill out and take it with water. So at least 2 occasions in the day, assuming you brush your teeth twice, you would be reminded of taking your meds. Now, I'm not suggesting that you try and create that device because it causes all sorts of problems, but putting pills near your toothbrush, putting reminders on your phone that set alarms off, and building it into your routine on a regular basis. And when you have multiple medications to take, asking the pharmacy to load it up into a Dosset box so that it's all organised for you. Because a number of people, particularly if you're rushing or you've got inattention or distractibility, you can't remember whether you've taken meds, and then you start getting the opposite problem, which is taking too much.
And in thinking of that question with physiotherapy and managing that, either of you, like managing to keep up with that routine, ADHD?
I think it's the importance of recognising that things like physio and rehab, they're not instant fixes. You need persistence. If you can keep doing it a little bit, but keep doing it and keep doing it and keep doing it, that's when you get the benefits. So it's a bit like blood pressure medication. You have to keep taking it to get the benefit, and you don't necessarily realise the benefit you're getting of taking a blood pressure medication. And I think some of those exercises and stretches that we do are similar. They're not going to work if someone overfaces you and gives you too much, and then you pay for it. That's a classic one, that someone gives you far too much to do, or tells you to get on an exercise bike when you know you can't do it. But getting a level that works for you and being able to do it really persistently, it just becomes part of the routine, because you get the payoff long term, not short term. And I think that's quite often, again, I think people do a couple of months and think, well, it still hasn't worked. A couple of months is nothing. You've had this all your life. You need to keep plugging away at it.
And I'll just add one thing to that. We say in ADHD, if it's not in your weekly ongoing schedule, if it's not on Monday afternoons I do this and on Tuesday mornings I do this, then it doesn't happen. So as far as possible, build in a routine that's fixed and structured and diaried and linked to alarms, and just reinforce those patterns. And if you don't have a physio appointment, then use the same time to do exercises at home.
Thank you. Back there. Yeah.
Hi, listening to you talk about ADHD has made me feel quite excited because my 15-year-old daughter is having a really difficult time at the moment. She is struggling at school, which is causing anxiety, and she's becoming more and more reclusive. She has EDS, she has POTS. I've tried to get her to see a counsellor, but she just will not go. She refuses to talk about it. The school won't help. Our GPs, we don't have one as such. It's just a continuing locum. How do I believe from what you've said that she probably has ADHD and this is what's causing all of the issues. How do I get that diagnosed when I haven't got a GP that understands?
Change GP.
I live in a very small place.
Ask to be seen by a different GP in the practice.
So when I see the GP, who do I ask to see?
So I think that it's really important when you have a GP practice to try to find the GP that's going to be most understanding. And in my field, I advise people to ask whether any of the 5 GPs in the practice have an interest in mental health. That's the first angle. So often they're a bit more understanding and not brushing things away. So it might be worth doing that. And I think try to build that relationship and with one person. And if you can't find it, then I think you have to shift GPs or put a complaint in to the GP surgery. In terms of what you're asking for, you're asking for your child to be referred to Child and Adolescent Mental Health Services, CAMS. ADHD is bread and butter for children and adolescent mental health services. It's probably amongst the highest percentage in terms of their workload. Less so with adult mental health, but I think you need to just push for a referral, for an assessment, and then the ball should roll from there.
Thank you.
But get the compression stockings on her first.
She has them already.
Top right.
Thank you for today. Before I was diagnosed with Ehlers-Danlos, hypermobile syndrome, I went to Edinburgh for 3 weeks on the chronic pain course clinic, and they tried to take you off all the medication. Now I've found I've got HEDS, and the antidepressants might not work, and the pain relief might not work. Is there a reason behind it for the HEDS sufferers why it might not be as effective?
Certainly in terms of the painkillers, you've already gathered it's not just EDS, it's chronic pain, full
Exactly,
stop.
yeah.
And the reason the painkillers don't work much is because they don't do anything about perception. For years and years and years, we've just focused on how pain nerves fire and looking at all the chemicals and all the genes, and we've never actually really started to look at brain perception. That's relatively new. Even now, Big Pharma are looking at lots of new molecules. They'll dare say there'll be more drugs. They're Big Pharma are desperate to have a really nice, expensive drug for chronic pain because it's so common. But I can't help but think it might help a bit, but it's still not going to be a cure because you're still not taking any notice of what the brain and perception does and that whole complexity of pain. There's not one molecule that controls the whole of pain. And even if there is, and you switch pain off completely, as you've already seen, you can't do that either. So there's a good reason why painkillers and medications used in chronic pain, they may be helpful, but they just don't make it go. So if you go into it saying, okay, I'm looking to see how much benefit I can get, if that benefit is enough that I'm getting a bit more control, which gives me a bit more quality of life, allows me to do more, that's a reasonable use of that medication. If it's doing nothing, or you're getting pills for the side effect of the pills for the side effect of the pills, you're on the wrong way. And actually that needs to be reviewed as what can I get rid of. And for some people, I have a lot of people that manage on very little. The odd paracetamol, the odd cocodamol, maybe a small dose of gabapentin pregabalin, but again, often at the lower doses. Other people do need more. So we are individuals. It is a balancing act, but you have to get that balance.
So it's not HEDS, it's chronic pain?
It's chronic pain.
Thank you very much. Thank you. Top left. Yeah.
I don't know really how to word it. I'm a bit confused about not feeling pain, but for example, my jaw dislocated quite often in the last couple of months, so I'm in A&E, and they'd ask me what's the pain scale, and I have a vague idea I have pain, but it's psychological. I'm wondering, is not feeling pain sometimes psychological disassociation, or are the pain receptors not actually, or they're damaged or something? And is it bad if I'm not feeling pain? Am I causing damage underneath the pain?
No, not necessarily. Again, bodies and brains adapt. So you probably found you're adapting. Now, it may also be that the jaw's capsule has stretched. You've got more give. So sometimes if you've got more give, things can move more, and it's got used to that. Then no, it won't be as painful as someone with a very tight, narrow jaw. The slightest stretch, you're going to know it. It tends to be the stretch that's the problem. So if it's already lax and more stretchy, that may be why you just don't get as much pain.
Is there a long-term problems going to happen because of the continuous dislocations, or is it because there's no pain, it's fine, it's just going to go in and out and put it back in?
Yeah, I mean, again,
I don't know if this is
the sort of conversation.
question.
Yeah, it's the sort of conversation you have to have with these. Usually, it's maxillofacial people that treat this sort of thing. So if you're not under a max fax, that's usually who it needs to be. Occasionally, if it's not max fax, it's special care dental teams, but usually it's maxillofacial. They would need to know structurally what the problem is. For some people, there are structural issues, and they do want to have a closer look. For other people, they say, actually, you don't have a structural issue, and actually it's just lax, so no, you don't need to worry.
Okay.
But often you need that little bit of information to know, and that's usually maxillofacial teams that deal with that.
Okay, thank you.
I'm going to do 2 quick questions on the app, and we're just against time, so as quick as we can. It's been talked about today about a link with EDS and autism. Have you also seen any links with gender dysphoria?
Well, I can say from my experience, I don't think I've seen anything in the literature, just from my experience of patients coming through our programme. Now, bear in mind, we're a tertiary centre, so we're the only UK centre that do a specific EDS rehabilitation programme, so I do tend to get the bad end of the spectrum of people. Yes, I see far more than would be expected in the general population. So absolutely. Is it out in a paper yet? No. Is it something I want to look at? Absolutely. So yes, I do. Do I see it more compared in the general pain population as well? Because I also see people with chronic pain that don't have EDS. I think I probably do see more there as well. But again, I don't think the literature is very good on this yet. So I think it's a watch this space one.
Thank you. And something that I know echoes around our community, there's often a misdiagnosis of Munchausen's. How does one avoid this hypochondriac diagnosis when some symptoms are often very unusual and troubling for us?
Oh, that's a complex one.
Million-dollar question.
I think, having reflected on the way Western medicine for a long time, I think we have a problem here, which is that evidence-based medicine is absolutely important. Obviously, every doctor will say, you know, it's really important for things to be backed up with studies. The problem exists now that often when a doctor doesn't know about something, they don't feel that there is enough evidence on it. They don't say, that sounds interesting, tell me more. They say, there's no evidence to support it, it's rubbish. This is a fundamental flaw in evidence-based medicine approach. You have to be flexible and open. The answer, and it happens a lot. What also happens when people are ignorant to something, and they just haven't been taught it, and they haven't put the pieces together yet. I hadn't been taught it before, and I didn't put the pieces together. And when I did, through learning, my perspective changed. The problem is, often when doctors are ignorant to something, rather than say, I don't know, and show ignorance, they say, it's a load of rubbish. So the outcome of all of this is to say, whether it's resources online, provide short but evidence-based summary of hypermobility spectrum, EDS, give it to the doctor. Don't then have the conversation straight away, ask them to read it. And then when they've digested it and reflected on it, then open up the discussion to avoid that ignorance block.
I also once saw, and I'm trying to remember for the life of me where, a useful session, and I can't remember if it's an EDS one or a chronic pain one, on basically training you to get the most out of your doctor. And it was a really good session. And it was simple things. One, your doctor's probably terrified of you. The moment you walk in the room, you will probably know more about the condition than they do. You're probably one of the more complex patients they have to deal with. They've got 10-minute slots for one thing, and you're probably going to come in with a shopping list. So your doctor's frightened of you. So number one, you need to learn how to get the most out of your doctor. So as my colleague has just mentioned, ideally you really should have a GP that knows you rather than a series of locums. When you go to see your GP, try to go with one or two really important things. Don't go with a huge list that they're just going to go, oh, they're nuts, I can't cope with this. Go with one or two really key problems. You might then have to have several visits over time, but that way you will probably get it solved one at a time. If you need referrals or you think you need referrals, don't come in demanding referrals. Guide them towards it so they think they've actually come up with the answer. And it can be as simple as that. Doctor, I've heard about this thing called autonomic instability, and I've got this and this and this. Do you think it might be? And then when you see them starting the penny drop, or maybe, well, I've heard that there might be this specialist somewhere that could help. Do you think it would be useful to see? So take it one bit at a time. Don't overload them. Take one or two bits. Take it over time. Don't frighten them. You want them on board.
Thank you. Lady on the right.
Hi, thank you. Firstly, I just want to say it's been really refreshing to hear you talking about EFT. I had that 15 plus years ago with a therapist who was an alternative practitioner, and it was what got me well way before I knew I had EDS, but it got me well with lots of symptoms I was experiencing. And the other thing that really worked well for me was nutrition. And I'm really interested, watching this, I have an EDS diagnosis, and I'm under consultants for POTS as well. So the OI really is a big pain for me, but I find that I manage my life the best when I'm active and when I'm eating well, and that sometimes is really hard. Some days I can't be bothered, and I don't particularly want the effort of having to do it, but I know there's a real strong correlation between what I eat and how I feel both physically and mentally. So I'm just really interested in, is it an interest of yours? And if it isn't, are you working with people looking at nutrition? Because medication's got a place, but if we're popping pills as a quick fix, but then I'm eating sugar or meat or things that are wrong for my body, then we're never going to get the results we're looking for.
Okay. So the answer to your question is yes. I've got a strong interest in nutrition. I actually trained as a nutritionist because I wanted to be able to have proper conversations about it. Because it's actually very hard to know what's true in nutrition because you get so much conflicting advice. So it is a centerpiece of the work that I do. And in my team, we have 2 nutritionists and a dietitian. And I'd say I offer nutritional evaluation this is in private practice, but to every one of my patients after I've assessed and if I've made a diagnosis. Not all of them take it up. And where they don't, I provide some guidance. And what I've learned over time is avoid anything radical. Radical changes, big diets. 1, you won't sustain it, and 2, it's not the right way to do it. Small, incremental, positive changes. So, you know, if you drink lots of Diet Coke, just say, okay, I'm going to stop drinking Diet Coke and replace it with fizzy water. I'm going to, you know, just small things that are not seen as a hassle or a restriction, but are seen about eating tastier and better foods. And the last thing to say on this is gut balance of bacteria is showing itself to be very, very important across the board, and particularly in mental health and with anxiety. And I think particularly with EDS, when the peristalsis through the gut is not coordinated because the collagen that's around is not contracting in the right way, you get stasis, which means you don't get a flow through. And when everything sits still, they fester and they get bacterial overgrowth and yeast overgrowth. So doing a microbiome analysis, so a stool sample and finding out what's going on in your gut, is a great way, and it's not done on the NHS, and it can be expensive, but it's a great way of knowing what's going on. And then, if you're going to use probiotics, you can have some targeted approach to it. But I strongly recommend people bringing fermented foods into their life, whether it's kefir or sauerkraut or kombucha or a whole variety. They taste great and they're superbly effective at repopulating the gut healthily. And yes, it does make a big difference.
Thank you. Thanks to everyone. I'm sorry that we have run out of time. We didn't get everyone's questions in the room, but everyone is hanging around today to answer questions. One question we did have come through the app is, what are the society doing to improve awareness of mental health and EDS without perpetuating the stereotype that people living with chronic illnesses, including EDS, are attention-seeking, hypochondriacs, and all of these things? The answer is, this is what we're doing. We're making this a safe conversation, a safe community for you all to live in and not be scared to talk about this connection. And we are incredibly grateful to people like this who are here without any charge, with their own time, dedicating themselves to our community to make things better. So thank you. Thank you.